speaker. It's my pleasure to introduce Dr. Magdy Selim. He's a professor of neurology from the Harvard Medical School, Beth Israel Deaconess Medical Center. He's a special interest in ICH, acute treatment and prevention, and he's the lead investigator for the Saturn trial, which is looking at the use of statins after ICH. So, Magdy, you have sent us a recorded talk, and we shall present that only. That's correct?
Yeah, sounds good.
Okay, so we start with.
Hello, everyone. It's my pleasure to be a part of this meeting, and I'm really honored to be joining all of you. And I want to particularly thank the organizers, particularly Professor Pacha and Professor Srivastav, for inviting me to talk to you about the use of statins in intracerebral hemorrhage. As many of you know, statins are probably the #1 prescribed drugs in the world nowadays. And this is clearly for important reasons. They are very effective and good drugs. But I want to start by asking a question. It's a provocative question to some extent. Can something be so good that if we use it excessively, it can cause harm? And I want to follow this with another question. Is it necessary that everything that's good for the heart is good for the brain? We know that statins are very effective in reducing the risk of major cardiovascular events and are very powerful in patients with ischemic stroke to prevent recurrent stroke and cardiovascular events. However, the benefits of statins in patients with intracerebral hemorrhage are not as clear. And to some extent, there is an equipoise whether we should be using these drugs in patients at high risk for intracerebral hemorrhage. It's not even clear when we should use them and when we should avoid them in this patient population. This has been a very controversial topic, and as you can see, there has been many editorials and many opinions published over the years, and they continue to appear in the literature every now and then for people questioning whether we should be using statins in patients with intracerebral hemorrhage or not. There have been many randomized trials of statin drugs. These are large trials, mostly including patients with cardiovascular disease and some patients with stroke. But probably the largest trial that was dedicated to stroke is the Sparkle trial. This was a trial for using high-dose atorvastatin in patients with non-cardioembolic stroke. They were randomized to statin, atorvastatin, or placebo, and they were followed for 5 years to look at the risk of recurrent ischemic stroke and the instance of cardiovascular events. And we know that statins were effective in reducing stroke recurrence and instance of major cardiovascular events in this trial, and this what led to our widespread use of statin drugs now to prevent recurrent ischemic stroke. In this trial, the instance of intracerebral hemorrhage was around 1.8%. However, it was much higher in patients that received atorvastatin compared to placebo. The relative risk for hemorrhage on statin was 1.68. And in subsequent analysis, it turns out that if you receive statins, if you were old, if you were a man, and if you had hemorrhagic stroke as the qualifying stroke in Sparkle trial, all of these factors were associated with increased instance of intracerebral hemorrhage during the follow-up period. Interestingly, around 2% in patients enrolled in the Sparkle trial, which amount to around 93 subjects, actually entered the trial because they had a hemorrhagic stroke and not an ischemic stroke. And as you can see in the table here, that patients that were randomized to receive atorvastatin did worse in all aspects, even in the instance of recurrent stroke or TIA, major adverse cardiovascular events, and even vascular death. So this was really the first time that the question came up about the safety of statins in patients with intracerebral hemorrhage. However, we need to be cautious. Although this is probably the only randomized evidence we have so far, this was a post hoc analysis, and this is a very small number of patients to really make any definitive conclusions. Subsequently, a very influential decision analysis paper came out using the Sparkle data in a hypothetical patient with lobar hemorrhage and a 10-year risk of cardiovascular disease of around 20% and an estimated annual rate of recurrence of intracerebral hemorrhage of around 14%. This is the rate that people think maybe patients with amyloid angiopathy would experience in terms of recurrent hemorrhage. According to this analysis, statin use in the survivors of lobar hemorrhage increased the risk from 14% to 22%. This is a relative risk increase of 1.57, and although it looks small, it was sufficient to offset any benefit from the statin, whether it's related to primary prevention or secondary prevention. And the conclusion was that avoiding statin was the preferred option in patients who survive a lobar hemorrhage. There was also a survival benefit when you look at adjusted or quality adjusted life years with the discontinuation of statin, which amounts to around 0.3 quality adjusted life years. And according to this paper, in order for statin therapy to be beneficial, the risk of hemorrhage really recurrence will have to be at least 10 times smaller than the 14% and closer to 1% or less than that. So these two studies kind of generated interest and debate over the use of statins in intracerebral hemorrhage. This is a recent paper that just came out. It's a population study, two studies getting together, one from Scotland and one from the UK, and basically looking at the natural history of stroke recurrence, hemorrhage recurrence, and instance of major cardiovascular events in hemorrhage patients over a 5-year period. And what the study showed is that the risk actually varies depending on the type of hemorrhage or the location of the hemorrhage, whether it's lobar or whether it is deep, and that in patients with lobar hemorrhage, the risk of recurrence usually tends to be higher, and the risk of ischemic stroke only increases in patients with atrial fibrillation. I want to look a little bit more closely at the table here, and what it shows you here is that the risk of hemorrhage recurrence in this population study was at around 5% per year with lobar hemorrhage and 1.8 with deep hemorrhage. Risk of ischemic stroke was almost the same. You can see, oops, I'm sorry, I need to go back. I'm not sure what I did here. You can see that the risk of ischemic stroke was around 1.8%, and the risk of major cardiovascular events with around 10% was lobar hemorrhage and 6% was deep hemorrhage. However, there is a little bit caveat to this, is that the 10% risk of adverse cardiovascular events actually included in it the risk of recurrent hemorrhage. So really the 5% is counted twice. And what it shows you is that in patients with lobar hemorrhage, the risk of hemorrhage recurrence is almost identical to the risk of major adverse cardiovascular events, which begs the question, which one is more devastating for the patient and which one would you like to avoid? I'm sure the answer will vary if you ask a neurologist versus a cardiologist, but it's something to keep in mind as we go along and talk about the use of statin in this population. There is also evidence that the use of statin is associated with microbleeds. This has been seen in hemorrhage patients, where patients on statin tend to have greater number of cerebral microbleeds, higher prevalence, and these microbleeds tend to be in lobar and subcortical locations, which is always implicated in amyloid angiopathy. This has been also shown in the general population. On the right-hand side, I just show you a study from the Framingham study, which included all patients, not just hemorrhage patients. This is a recent paper from Germany, and interestingly, it shows that among patients that use statin, the instance of lobar hemorrhage tend to be more frequent than patients who do not use statin. And if you look closely at this table here, you can see that the instance of hemorrhage tend to be greater with higher doses of statin and increased duration of the use of statin. There is a lot of evidence and accumulating data to suggest that hypercholesterolemia is protective against intracerebral hemorrhage. And this is one of the studies. Interestingly, it showed that if you're on statin, it can attenuate the protective effect of hypercholesterolemia and increase the risk of lobar hemorrhage, particularly in patients who carry ApoE2 genotype. Again, this is a genotype that has been linked to amyloid angiopathy and suggests that the use of genetic markers may help to identify which patients might benefit or might be hurt from the use of statin. Same data have been duplicated in a much larger Italian study, and again showing that hypercholesterolemia is protective and that in patients that use statin, the effect of hypercholesterolemia is attenuated and that they tend to be propensity for increased instance of lobar hemorrhage. So the evidence is slowly building up. Why would statin increase the risk of intracerebral hemorrhage? This figure summarizes why, because they have antiplatelet effect, they decrease thrombus activation, and even have fibrinolytic effects just similar to TPA. So the same things that would make statins very efficient in situations where thromboembolism is a problem could actually make them harmful in patients who are at higher risk for bleeding complications or bleeding tendencies. There is observational data to suggest that not just that hypercholesterolemia is protective, but that low LDL actually is associated with increased risk of hemorrhage. And we can see here a study on the left-hand side from the United States, the Women Health Study, that LDL lower than 70 is associated with increased risk, not just of intracerebral hemorrhage, but also subarachnoid hemorrhage in general population. And on the right-hand side, a larger study from China, again showing similar results. Even genetic study, this is a study that looked at a polygenetic risk score for the lipid profile, and again finding that genetically elevated LDL is associated with decreased risk for intracerebral hemorrhage. And as you can see here, lower LDL is associated with increased risk of hemorrhage, in particular lobar hemorrhage. So the question that comes up, does the dose of statin matter? If they have antithrombotic antiplatelet effect, would a higher dose cause more bleeding? Just as we talk about aspirin, baby aspirin versus full dose aspirin. This is a meta-analysis of 7 randomized controlled trials, including almost 32,000 patients, and it did show that the risk of intracerebral hemorrhage is higher with higher doses of statin. However, this finding is not consistent. This is another study from Taiwan to suggest that it's not really the dose that matter, it's the type of statin, whether it's lipophilic or hydrophilic. Lipophilic statins can easily cross the blood-brain barrier and therefore easier to cause increased intracerebral hemorrhage, unlike hydrophilic drugs, which have a harder time getting into the brain and crossing the blood-brain barrier. On the other hand, there are studies to suggest that statins are actually good for hemorrhage patients. This is just a selection of these studies. Some of them show that if you stop statin during hospitalization, this is associated with increased mortality. Other studies show that if you're on statin or if you start statin, this is associated with improved recovery and functional outcome. And here's an observational study on the right-hand side from Israel to actually suggest that if you're on statin, that decreases the instance of intracerebral hemorrhage. This is again the German study that we mentioned earlier, and to show you that if you're on statin expectedly, the risk of major adverse cardiovascular event would be less than if you're not on statin, and that if you're on statin, this is associated with better functional outcome as assessed by modified Rankin after 1 year. There have been many meta-analyses looking at the relationship between statin therapy and hemorrhage, but most of these meta-analyses really included patients that have cardiovascular disease and very few patients with ischemic stroke. And this is one meta-analysis to show what we know is that statins are beneficial in patients with ischemic stroke, but less so when patients with hemorrhagic stroke. This is another meta-analysis to show that there is no difference, but the authors correctly point out the problem that we have with everything that I just mentioned, is that a lot of these studies are observational. A lot of the studies did not include hemorrhage patients, and even when they did, there was really no stratification of the location of the hemorrhage. Is it lobar, which most of the time is due to amyloid angiopathy, or is it deep due to intracerebral hemorrhage? This is the most recent meta-analysis, which restricted the analysis to only randomized controlled trials. And what you can see on top, that there is a slight increase the risk of hemorrhage in these trials with the use of statin that included some stroke patients. And the risk is particularly magnified when you look at Sparkle and the patients that used statin while they have intracerebral hemorrhage. The same trial assessed the risk in patients on PCSK9 inhibitor, and what it shows here is that the risk of hemorrhage is much less, and actually hemorrhage is not a concern in the trials that used PCSK9 inhibitors. The authors take this to conclude that it's probably safer to use PCSK9 inhibitor in patients with hemorrhage to prevent the risk of recurrent hemorrhage. The problem with this is as follows. This is just an example from these trials, and I want to start with the one in the middle, which used PCSK9 inhibitors. These trials excluded patients with intracerebral hemorrhage and had very few patients with ischemic stroke. They also excluded patients with poorly controlled hypertension, so they did not have significant cerebral small vessel disease, which we all know is associated with increased risk for hemorrhage. So really, these drugs have not been tested in hemorrhage patients, and they might be safer, but the truth is we don't know the answer. They need to be tested first. Then in the other trials, you can see that the representation of patients with stroke in general with either very low or minimal, if none, for patients with intracerebral hemorrhage. So you cannot use this to make generalization and conclusion to say that what works for cardiovascular patients is the same that works for ischemic stroke patients, is the same that works for patients with intracerebral hemorrhage. The problem with all of these trials really is the observational retrospective nature and just the difference in the population that we're talking about, patients with intracerebral hemorrhage that were not included or represented in these trials. This study is from Cincinnati, and it highlights the problem with all this evidence that I just represented. So this looked at the ERIC data set or database. ERIC is an observational study, very large number of patients, 3,000 patients. So basically they went back and they looked what happened to the patients that were on statin and they continued the statin after they had their hemorrhage or were prescribed statin during hospitalization. And what they found is that these patients actually do better. There is decreased mortality and improved functional outcome when they follow them up. However, they went back and did something very smart. They did propensity score and tried to account for the factors that might influence the decision to use a statin. And when they did this, they discovered that there was no difference. So the bottom line is that there is prescription bias that can affect these results in observational studies. If you have a patient who is very sick and you think that they're going to die, you stop their statin and then they die and you attribute the death or the poor outcome to the statin. If you have a patient that looks like they're going to survive and do well, you're prescribing the statin and they do well, and again, you attribute it to the statin, but this may not be necessarily the case. So we have to be careful when we use observational data And we have to be careful to look carefully at the composition of the various trials and studies, because we cannot use observational data to make clinical decisions, particularly if the difference between the different interventions is not huge. So there is no consensus whether we should be using statins or not in patients with intracerebral hemorrhage. There are different opinions, and this is based on observational data, which has limitations, as I just mentioned, and our own assessment of what we think the risk and benefit would be. There are no prospective or randomized data except for the small number of patients that were enrolled in Sparkle trial. And we really don't know much about the effect of continuing or stopping statin on the risk of ICH recurrence, on the instance of cardiovascular events in this patient population, and even on cognitive function and neurological recovery. And this led us to start the Saturn trial, which is currently ongoing in the United States and Canada. So this is a study trying to look at the effects of continuing or discontinuing statin on the risk of symptomatic intracerebral hemorrhage during 24-month period, a 2-year period in patients who develop lobar hemorrhage while they are taking the statin drug. At the same time, we're trying to look at the instance of major adverse cardiovascular events and ischemic stroke. In addition, we're trying to look at what happens to the cognition of these patients, what happened to functional recovery, what happens to their quality of life. Again, there is this question of what's worse, having a recurrent hemorrhage or having a cardiac event. And one of the things we're really interested in is whether we can use ApoE genotype for personalized medicine. Can we use the ApoE genotype to help us decide which of these patients can benefit or can be harmed from the use of statins? So this is a prospective, randomized, probe design trial. It's open label. The endpoints assessment are blinded. Almost 1,500 subjects at 140 sites. We randomize patients that come in with a lobar hemorrhage while taking a statin within 7 days from the incident of hemorrhage to either continue taking the same drug at the same dose or to stop it. And the randomization rate is 1-to-1. And we check for ApoE genotype, and then we follow them for 2 years, as I mentioned, to look at the risk of recurrent hemorrhage, major adverse cardiovascular events, recovery, cognitive function, and quality of life. So hopefully, when we end this trial, we'll have a solid evidence to guide us on what to do with a statin use in patients with intracerebral hemorrhage. Thank you very much for listening. I'm happy to entertain any questions at this point in time.
Thank you very much, Magdy, for this very informative lecture, because I think this controversy always lingers on, especially when we're treating patients with high dose statin after ICH, or actually deciding to prevent cardiovascular events post ICH. So the house is open for questions. I don't see any specific questions in the chat box related to your talk, but we do have a live question from one of our students at the Institute.
Sure.
So, Dr. Saman would like to ask you a question.
Sir, I would like to ask, if we have a patient of deep ICH with a low risk of recurrent ICH, and he has dyslipidemia and a high ASCVD risk of, say, more than 10%, is there evidence to suggest a particular duration after which we should start statins, or can be started straight away for that kind of a patient, where we know that the risk of recurrent ICH is low and the ASCVD risk is high?
Yes, so for patients with deep hemorrhage, that's mostly due to hypertension. Probably the evidence for stopping statin is less, because again, it's a balance between what's the risk of recurrent hemorrhage and what's the risk of having a cardiovascular event. As Dr. Majaz mentioned early on, the risk of recurrence after a deep hemorrhage is around 1%, 1-2% per year. So the risk of cardiovascular events may be a little bit higher than the risk of a recurrent hemorrhage. The story is different if you have cerebral amyloid angiopathy, where the risk of hemorrhage recurrence is actually much higher. So that's why there's a difference. So for a deep hemorrhage, I probably would continue the statin if there is a cardiac indication for it.
So is there a specific duration, sir, in which we should avoid prescribing statins, for example, in case of lobar ICH versus deep ICH? As in the acute period, should we avoid giving them, or is there evidence to suggest that?
So the truth is, we don't know. I showed you one of the slides where different opinions, everyone telling you what to do. And one of this opinion was from Larry Goldstein, who is one of the experts in the US and interested in this lipidemia and was one of the investigators in the Sparkle trial. And what he suggested, at least what they found in the Sparkle trial, is that you start to see the benefit from statin in preventing cardiovascular events and ischemic stroke after 2 months. So he actually suggested that you can probably stop statin in the acute phase for up to 2 months and then start them again. But again, this has not been studied. This is just extrapolating data from another trial.
Thank you, sir. Thanks a lot.
Sure, you're welcome.
Sorry. Magdy, I would just like to ask you that, as you rightly pointed out, that in some of the studies, we don't have too many patients of stroke or ICH included. So do you think this whole confusion about statins causing ICH is driven from cardiovascular trials, which are not stroke trials, where they have a tendency to really lower the LDL in patients? I think at least in India, we don't use very high dose statin post-stroke. In fact, our usual atorvastatin doses on an average would be 40 milligrams. And after a few months, if they have stabilized, we generally tend to bring them to a maintenance of 10 or 20 milligrams. But cardiologists tend to treat them at a high dose for a very long time. So what is your opinion on that? What's the real best dose for treating these patients?
So the honest answer, I don't know, but I completely agree with you. I think we overdo it with the dose, and I always thought everything in moderation is good. I think that's probably one of the problems with the Sparkle trial, which is the trial that's causing a lot of this confusion, is that it was the highest dose of atorvastatin that you could use. And would the results have been different if they used a lower dose of statin? I don't know, but perhaps. But again, I showed you some conflicting data about whether the dose is important or not. In my own practice, I do exactly what you do. I never actually start the 80 milligram of atorvastatin. I start a lower dose and then I follow the lipid profile and can adjust it from there.
Thank you. So Magdy, we have two more questions. One, so we'll take them quickly. Dr. Sunil Narayanan and then Dr. Awad. So Dr. Sunil, can you please ask your question?
Thank you, Rohit. Dr.
We can't hear you, Dr. Sunil.
Yeah, I can't hear him.
Is Dr. Majas also around, or?
Dr. Majas
around.
We can't hear you, Dr. Sunil.
Can you hear me? Is it better?
No, it's very, very faint.
Oh, sorry. I don't know what to do now. I kept the volume maximum and I'm very close
Okay.
to the phone.
No, we can't. I
Is
think
it- yeah.
we can't hear you, sir. Can you put it on the chat box? Then I can actually ask sir to.
Okay. Is the same? Maybe this question
Want
applies
to answer
to
that?
amyloid disease also. Amyloid angiopathy.
We couldn't hear you, Dr. Sunil. I think you can put it on the chat box and I'll take the next question. Dr. Awad, can you please speak out your question?
Yes, sir. Good evening. Am I audible?
Yeah. Good. Yeah.
So, congratulations, Magdy. I think it was a wonderful review. And you showed one of the meta-analysis, which is me only, which you quoted from Acta Neurologica Scandinavica, which I had done. So that showed a relative risk of 1.53 of risk of ICH following statins. My take is you said with PCSK9 inhibitors, it doesn't matter the risk of intracerebral hemorrhage, even though the lipid levels were, LDL levels were even less than 30. So I still feel, do you suggest that the trend should be risk and the prescription of statins versus PCSK9 inhibitors?
No, so that's exactly the point I made out. So the problem was all the PCSK9 inhibitors trial is that one of the exclusion criteria was any patients with history of intracerebral hemorrhage and patients with uncontrolled hypertension. So they really excluded patients that are high risk for hemorrhage. So we don't know, and that's why I said they might be safer, but they have not been studied in patients with history of intracerebral hemorrhage. So I'm not sure we're ready to use them then. Does this answer your question?
No, I need one, your maybe experience. If a naive patient of a maybe ischemic event or a ischemic coronary artery disease, so do you suggest that even if we have idea that, oh, there are no microbleeds and the hypertension is controlled, but still there is hypercholesterolemia, and do you suggest to go for PCSK9 inhibitors versus statins? Would that be a take in future or?
No, I am not really ready to use PCSK9 inhibitors in patients with hemorrhage yet because they have not been studied in this patient population. Whether it's lobar hemorrhage or whether it's deep hemorrhage, just this population have not been studied. You can use statin if you want to. And I would add that, at least in the US for now, it's not easy to put someone on PCSK9 inhibitor without showing to their insurance company that they did not tolerate statin first or statins were not effective. So it's not easy for us to do it, even if we want to.
Yeah, it is same over here also. Thank you so much.
Sure. Thank you.
Last point that I'll ask Magdy has been typed by Dr. Narayanan is that he just wanted to hear opinion from the panelists, including Majaz and you, about small vessel disease, strokes and hypertensives and amyloid angiopathy, infarcts versus hemorrhage, a function of genetics, BP, or tandem effects. So his opinion about, in general, about the small vessel strokes and hypertensives and amyloid angiopathy.
Majaz, do you want to go first or do you want me?
No, you go ahead first. I'll follow.
Well, I think I heard part of the question, and I think the question was more, why do some people with these risk factors develop ischemic stroke and the others develop hemorrhagic stroke? And is this for genetic reasons or not? Is this correct? Did I understand? Yeah. Yes.
In the small vessel mainly.
Yeah, it is actually a very good question. I always thought that you get to the hypertension as like an end stage problem of the disease. But I'm not sure I know a definite answer for that, whether it's genetics or not. I'm not sure genetics play an important component in this. It's just really a matter of luck. And if there is significant damage to small vessels, then you probably end up more with the hemorrhage than with the ischemic stroke. Majaz, I don't know if you want to add something.
Well, there have been some genetic studies showing the propensity to link small, in-vessel disease or leukocytosis with ischemic strokes in some genetic markers that have been just discovered. But in the end, I mean, the question really is that if there's it's a multifactorial thing. It's not just one thing. I think if you have severe hypertension, you are an alcoholic, you have done other things. I mean, there's a whole group of things that would make you more conducive to intracerebral hemorrhage rather than an ischemic infarct. And as I said, the answer is not absolutely clear. And all I can tell, going to this and to the previous question that Dr. Narayan asked also, was that in the last 8 years, and I can go back into the data set again, we have been using high-dose statins almost in all patients with acute ischemic strokes. And as you know, I've had a very hard time trying to find lobar hemorrhages that fit the statin criteria going forward, So to me, personally, I don't see what we are, it was a great talk, but I don't really see the extent of intracerebral hemorrhage risk that has been And I think part of that is because most of these are observational studies. They have exclusion criteria that have excluded patients. And so which is why the Saturn trial is being done, to actually see if there is any rationale to this or not.